We have started to stream right now. Have a nice conversation.
Hi, Kadriye.
Hi, Yasemin. Welcome.
Thank you. How are you?
Doing well. How are you doing?
I'm okay, thank you. Shall we wait just a little bit to see if people are coming in, logging in?
Why not?
Right. I'm just following this on my phone. I'll see. Okay. As it's going to be saved live, I guess we can maybe start with introducing ourselves and making a start that way. And if anyone comes in, we can just continue welcome them. Shall we?
Yes, that sounds wonderful.
Okay, so there's about 13 people watching us at the moment. So welcome all. It's so nice to see people logging in with the weather warming up and, you know, summer periods, I guess, on a Sunday. I'm really excited to have these discussions in English, especially because we can, I guess, spread it to a wider audience. So today we're going to be discussing a problem a lot of people struggle with, panic disorder. So we're hoping to spend about 20 minutes explaining what panic is, what panic disorder is, how we separate these two, because these terms can be mixed up a lot. I guess when people experience any heart palpitation, they often say, I've got a panic attack, but is it really a panic attack? I guess it will be important to go into those details. And remaining 20 minutes, we can talk about maybe how we treat it. And then we'll leave questions for the end of the show. So please keep tuned and stay with us. So before we go on to explore what panic disorder is, I'd like to introduce myself. I'm sure many people who's logging in don't know me. My name is Yasemin. I'm a psychotherapist. I studied psychology in London. I have a background in cognitive behavioral therapy, CBT in short. We may refer to CBT during the program. And I have a background in Islamic counseling as well. I worked for National Health System, NHS in short, in London with many presentations, including anxiety disorders and panic as well. And I lived most of my life in London and recently moved to Turkey, and I've been in Istanbul for about 8 months now. I'm living here and loving it. And I work both with Turkish and English-speaking clients. And would you like to introduce yourself, Kadriye, and perhaps make a start to our topic?
Yeah, thank you so much. And around those 8 months, you've also come by our clinic and kind of been a part of our team. So welcome to our team too, Yasemin.
Thank you. It's a pleasure to work with all of you. I love it.
Yes, that's wonderful. So I too am actually a psychotherapist, just like you, with a cognitive behavioral therapy orientation. Also, prior to my psychology education, I completed a bachelor's in physiotherapy. So having this background, actually physical symptoms that surface due to unnoticed or neglected psychological issues, which we actually refer to as psychosomatic health problems, is specifically of interest to me. And as we'll be discussing in this talk together, panic disorder is similarly actually a very physical-like looking condition, but it's actually psychologically originated. So that's why it's actually a condition I also work very closely with in my clinical practice. And I've been continuing my clinical practice for around the past 5 years. And actually today, the topic is a really important one in the sense that it's pretty common, right, Yasemin? I think approximately, like around 3 to 4% of the general population suffer from a panic attack at least once in their lifetime, right?
That's right. And I guess that equals to about 1 million people who actually suffer from it. But I guess this is what the stats are showing. I'm pretty sure that many people don't seek assistance and support in these situations who suffer panic attacks. So I guess we can say it's probably more than what the stats are showing.
Mm-hmm.
So
also, women tend to come to our clinic more. We seem to see it more commonly in women, but it also might be the case that men experience it as well, and maybe they don't seek as much help. But still, the stats seem to show that it's more common among women, right, Yasemin? It's like more.
Yeah, I guess
generally.
I would say I agree with that, especially in my clinical practice. I would say I have seen maybe a few gentlemen, but mainly females who come across to seek treatment. I guess there's a cultural reason for this as well, which we may go into later in the session.
Yeah, can be, absolutely, I agree.
Yeah. So how would you describe panic disorder?
Well, Yasemin, I think first we can talk about the nervous system a little bit, because when we look at it from a biological sense of the term, the nervous system is the most important system in panic disorder. And when we talk about the nervous system, I mean, there are two important divisions. There is a voluntary nervous system, like I'm raising my hand saying hi to you, like that's a voluntary action. Mm-hmm. But aside from that, we also have an involuntary nervous system, which is also referred to as the autonomic system. And this system is actually the one that's specifically important in panic disorder. And I think it's it might be more beneficial to talk about this over a diagram, because there are two main divisions of the autonomic nervous system that are important in panic disorder. Mm-hmm. So we can imagine like a diagram like this, where we have the elapsed time on the horizontal direction and
hold it a bit more close.
Fear or anxiety or stress buildup. Yeah, sure.
Yeah,
sure. Is it better?
Yeah, I think that's better.
Okay, that's wonderful. Yeah, so I mean, over a course of time, our body might sense certain stimuli that bring about fear, anxiety, or stress. This might, for example, be a wriggling noise in grass, and we might start being aware of that stimuli and that noise and start thinking that it might be a snake. Now, until the time that we're actually certain that it is a snake, this system, which we call the parasympathetic system, which is our actually safe and calm system, is active. But at the moment that we discover that it is in fact a snake, and we realize that there's actually danger and a threat involved, the sympathetic nervous system is activated. And this system is actually arranged in such a way that it is activated without the involvement of any of our prefrontal or cognitive areas, upper higher cortical areas. It actually directly activates a reaction we call the fight or flight reaction, mm-hmm. and it immediately stops all unnecessary actions in our body, only to allow us to either fight with the danger we've sensed or flee from it. And this brings about a lot of symptoms. It might be increased heart rate, rapid breathing, muscle tension. And talking about these symptoms, actually, Yasemin, I think it's very similar to what we refer to as the symptoms in the panic attack, right? Would you like to elaborate on that a bit?
Yes, definitely. So what you're saying there in terms of fight or flight, it's our body's alarm system. So when the body's alarm system is activated by an adrenaline rush, mm-hmm. because we perceive something as threats. So this can be an internal trigger or external trigger, and by internal trigger we mean mainly the physical symptoms. So I think it will definitely be helpful to explain what panic attacks are firstly. So panic attack is a sudden and intense surge of overwhelming anxiety and fear. I'm saying intense because we all at times experience anxiety, right? Like before the program, we were kind of making sure, is everything okay? Is our Wi-Fi kind of good? And is our connection okay? Are we going to get disconnected? If we get disconnected, what will we do? We're kind of overthinking, planning things. So we felt a bit anxious, and I felt it in my body as well, like my breathing changed and my physical symptoms changed as well. But the difference to panic will be that panic will be intense. So there may be threats a person perceives, like we said, and when the fight or flight is activated, people start scanning for danger. It can be external danger, external focus. They give their focus in the external stuff, or it may be their body. They look for evidence of threats. And some of these may be, like you said, hearts beating fast, shallow breathing, changes in breathing, dry mouth sometimes. There's about 13 symptoms in total. I'm going to count the ones that I remember. They sometimes notice tightness in their chest and start worrying that it may be something bad. And they may have shaking, dry mouth, nausea, feeling dizzy, feeling detached from their body, feeling strange to themselves and the environment as well, including strong sense of losing control. I would like to also show this with a diagram as well, because it really helps working with clients to show exactly what happens, because people who experience panic are really in their head, and it all kind of happens in the head. It helps to look at it in a diagram. So it starts with the anxiety, as you talked about, the fight or flight response, right? So it starts with, they start noticing the physical symptoms, right? And those physical symptoms are the ones that I've counted, but they don't always experience all of them. It can be 4 or 5 of these symptoms for us to define it as panic attack. And then what happens is, these physical symptoms are often results in people thinking that something bad is going to happen to them and something is wrong with them. So they must be going crazy or dying, or we call these catastrophic misinterpretations. So they misinterpret what's happening in their body. So if they miss a heartbeat, they may interpret that as, I'm going to have a heart attack, or I'm going to go mad. So it's very frightening to experience these. And it starts with anxiety, physical symptoms, then the misinterpretation. This looks like a circle, right? But it can be a vicious cycle, which we are going to go into a bit more. I'm going to refer to this later. So it can be very frightening to have these symptoms. It's quite horrible as well. And people often want to escape these situations because it's not pleasant at all. And they often end up in A&E, accident and emergency of the hospital. So having 1 or 2 panic attacks over the course of a lifetime isn't uncommon, and not everyone who has a panic attack have a panic disorder. So I'm going to pass it on to you, Kadriye, for you to explain, how can we explain how it becomes a panic disorder?
Yeah, just before we go into that, it's a very good point. As you said, they're so afraid, and it's so, fear-provoking. It's absolutely, they do find themselves usually at the emergency room trying to understand what happened. But Yasemin, it's really important, right, as that actually that reaction, they do think that they're going to die, but the sympathetic nervous system is not formatted in a way that it's going to kill us. We both know very well that actually this reaction keeps peaking, especially for the first few minutes, but after 15 to 20 minutes, it starts subsiding and returning back to the calm system, in which case the parasympathetic system comes back in and tries to calm the system down. So actually, there is a very big buildup. Yeah, it's very freaky, but in fact, it's going to subside. We can only run away from a snake for so long. After a point, right, we'll have shortness of breath and basically collapse on the ground.
Yeah.
So actually, it is a normal body response, but in this case, it happens to a wrong alarm, basically. We have very scary symptoms. It is a normal reaction that should happen in the case that there is, in fact, danger. But in this case, there's no danger, right, Yasemin?
Yes, that's right. And as you said, it is not a real threat. So this fight or flight, the alarm system is a survival mechanism, and we need it. It's for our survival. But when we perceive things as a threat, when there is no danger, it then becomes a bit of a faulty alarm. And we can maybe use a smoke alarm example with this. So let's say that you have you fitted a smoke alarm in your kitchen, in your house, for your safety, to keep yourself safe, in case something on fire, in case you burn something, a toast or whatever. And we often do this, right? So let's say this sensitive smoke alarm is picking up anything that's kind of on fire. Let's say your toast is on fire. So the alarm went off. What would you do? Would you call the fire brigade because the alarm went off? Would you?
I guess I won't. I mean, because I think I can control that situation. Right.
Why wouldn't you call the fire brigade? Because the alarm went off. Right?
Yeah, so because it's a toast machine. I can pull the plug out and kind of control it, I think. Because I saw it also before. I mean, I know what's going on.
Yeah, that's it. So when we give examples like this or metaphors, I guess it makes more sense. So you're saying that you won't call the fire brigade for that alarm. This just like that, we ask the same question to our clients, and often they say, no, I wouldn't. Why would I call the fire brigade? Because I know it's only the toast. So it's just like that. So what we want people to understand is that when you have this knowledge about high anxiety symptoms, you can notice that this is the alarm, body's alarm, not like them, but don't do anything about it, which we are going to go into detail. So as you said, you won't call the fire brigade. So how will this then transfer into panic disorder? And how can we separate panic attack from a panic disorder?
Yeah, exactly. Wonderful. Yeah, so as we said, I mean, the alarm reaction actually is going to start subsiding after 15 to 20 minutes. But what happens is that people don't know this. And they're very afraid of those symptoms. So they go to the doctor, and the doctor usually does do a physical checkup. And the doctors usually say, I mean, it's about nerves, it seems to be psychological. But what transforms these panic attacks in some people into panic disorder is that they are almost certain that the doctor missed something. I mean, they're almost certain that they have a very serious physical disorder. And they start having what we call as negative anticipation, which is an expectation that that attack will happen again. For example, if they had this attack last night while they were sleeping at a totally unexpected moment, and they were, I mean, it was so scary to wake up in their sleep with their heart beat fast, their breathing off, I mean, and going to the emergency saying that nothing's wrong. Once they might think that that hour and that sleeping moment will predict another panic attack. So there's negative anticipation, Yasemin. They're expecting that will happen again. And then added to this, as those symptoms were so freaky, they have what we call an increased focus on their body symptoms. So, for example, I mean, we walk up and down the stairs at our clinic. Our clinic's a few stories too. We keep running up and down those stairs, right? I mean, usually when we go up those stairs, after a few steps, naturally, we do have shortness of breath a little, and we might have increased heart rate too, but we know it's because we went upstairs. What happens in this case is that they immediately link those symptoms, because of their increased awareness on their physical symptoms, to a possible panic attack coming again, in which case they might even develop self-generated panic attacks. So we have a situation where there is negative anticipation, usually linked to the moments in which they did have the panic attack, maybe most likely the first panic attack, and then an increased focus on body symptoms, which we call body scanning, to this increased awareness on these symptoms. These are two main components, but aside from this, you and I both know, I mean, there are also avoidance and safety-seeking behaviors that also need to exist, which makes a panic attack turn into a panic disorder. So can you talk about those a little, maybe, Yasemin? What are these avoidance and safety-seeking behaviors? I mean, we do see them often in panic disorder.
Sure. What you said is interesting. When we walk up and down, we feel the same symptoms, but we don't misinterpret them. I guess that's exactly what it is. So people feel fear, and that fear becomes so fearful that they start fearing the fear, which then keeps the cycle going. So when we look at this vicious cycle, we want to identify what maintains this. And safety-seeking behaviors are things that people do to plan not to have another panic attack and to keep themselves safe. And what are these? These may be things like they may not be able to go out alone, always carry someone with them. They may call someone immediately in an emergency or in a threat. If they perceive something as threat, they start distracting themselves. They may carry water or medicine with them. And like you said, if they've experienced panic in a situation, for example, in a supermarket, on the tube, or in a crowded place, they start avoiding these places as well. The idea is, if I go to this place again, I'm going to have another panic attack. So they avoid these places. If they had it in a supermarket, they will start doing their shopping online. So they modify their life accordingly. They don't even notice what they are doing, really. So this is what we want to look at, to see what kind of safety-seeking behaviors they're doing or what kind of avoidance behaviors they are doing. I also want to say, on the short term, these safety behaviors, like not going to the supermarket and not traveling on the tube, it gives them a temporary relief. Oh, I don't have to go through this because it's so scary, and I didn't have a panic attack because I kept myself away from it. But on the long term, what happens is it makes this problem going, and it also feeds into this cycle as well, because it feeds more into the anxiety, the catastrophe, the bad scenarios that they're creating, their mind's creating. So they believe that because they employed these safety-seeking behaviors, they believe that the misinterpretation, which is I'm going to go mad, I'm going to have a heart attack, didn't happen because of them. Such as, like ending up in A&E because of the fear, right? So this maintains the problem and the beliefs are not challenged. So what we can say is that the anxiety starts and the physical symptoms. So the safety-seeking behaviors, people try to cut it from there, the cycle, because that's when they employ it so that they don't have these physical symptoms. They find it so scary, right? But what we do in therapy, which we are, again, I'm just going to explain a little bit later, is we want to cut it from misinterpretation parts. So they have these physical symptoms, just like the fire alarm. The fire alarm goes off, but they don't do anything about it. So they cut it from here so that the cycle is disconnected somehow, right? And it then has a knock-on effect on other bits as well. So
so I guess we have a situation where we have very scary symptoms, right, Yasemin? We went to the accident emergency, did a physical checkup. They said it's about nerves, but we're still very afraid. I mean, we're certain something's wrong with us, coupled with then a negative anticipation, body scanning, and then what you refer to as avoidance and safety-seeking behaviors because of the misinterpretations. So it's a pretty vicious, exhausting cycle, right? And as you just mentioned a little bit ago about the therapy, how do we solve this? I mean, these people really come to us after repetitive attacks, usually after going to physical checkup. They're usually exhausted. I mean, what do we do? How do we help them out, Yasemin?
Yeah,
I know you know about the theory A and theory B. Maybe we could talk about that a little, because we do give them this psychoeducation. But theory A and theory B is specifically important, right? When they come to us with all this stress and exhausted.
Yes. Just before going on to that, I've also remembered a metaphor that we use often with panic or anxiety disorders, I guess, because it's important to give psychoeducation about this and increase awareness that this is not dangerous. And what they're doing is adding to this cycle and continuing the cycle, and it's maintaining what's happening, right? So if I can explain a bit of a metaphor, talking about the safety-seeking behaviors, I'm not taking it lightly at all, because I'm aware that people do really feel these symptoms in their body. And I've experienced panic attack once in my life, and it was horrible. It was just a few minutes, and I hated it, and I really thought I was dying. But knowing and having this knowledge, I guess I didn't misinterpret it. But those few minutes was enough for me to feel like, oh my goodness. And as soon as you say, oh my goodness,
right,
and continues it. So I want to give an example about this man who travels on the train every day. He gets pieces of paper from his bag, he rips them and throws it out the window. He does this every day, traveling. The conductor who watches him every day, with curiosity, approaches him and says, "Sir, I've been watching you and you've been doing this, ripping paper and throwing out the window. What is this for?" And the man says, "It's to keep the elephants off the railway." And the conductor says, "But there are no elephants on the railway." The man says, "See, it worked." So I guess, what do you think this man is doing here?
Actually, it's a safety-seeking behavior in our terminology.
Yeah.
However, I mean, there's so scary symptoms, actually. I mean, these people do, and we don't want to minimize it anyway, you and I, with this example, but it's a very good example. I mean, because he's actually doing that every day. It's the way he's surviving. Similarly, a cup of water or having some sort of pill in your bag, those type of situations. I mean, because it's very freaky. For example, it's leading him to do this every single day, right, Yasemin? Though maybe he hasn't experienced a panic attack every day for a very long time.
Yes. So we will then ask, what would you say to this man? What does this man need to do? Right? So I guess this will be then getting people to think about the safety behaviors that employing, how it maintains the problem, and also what they need to do to update this knowledge. And this, I guess, is a pretty difficult scenario. And I guess the question goes to now how we treat it. So the treatment, of course, is available, especially with CBT. It's proven that it has the best impact. It's evidence-based treatment that works quite well with panic disorder.
Yeah, actually, even the psychoeducation, among many of the disorders we see, right? The psychoeducation can break up so much in the session room with these clients, right?
That's right, yes. And sometimes even 1 or 2 sessions, making them aware in the cycle, maintaining factor can also be very helpful as well. So people then learn how to manage it. So if I can go on to Theory A, Theory B here.
Yeah, please. It's very important.
With panic, people often come to us after having a physical check. So they first go to A&E, have convinced that there's something bad happening with them, such as fainting or heart attack, or that they're going to die. So what we usually say is, okay, so this is what you came to us with. If we say this is Theory A, I have a heart problem. What do you do when you believe this? You go to emergency room. What else do you do? We count those, right? We make a note of these. Because they believe that they are going to have a heart attack because they have these symptoms. So we say, okay, we're not dismissing what you're feeling and believing, but let's come up with an alternative, Theory B, and let's make a note of this. So if we say Theory B is, I have a panic disorder and I misinterpret physical symptoms of anxiety as catastrophe. How will this sound? Once we understand this, we then start targeting beliefs, physical symptoms, and avoidance and safety-seeking behaviors. So we'd like to maybe talk more about how you work with adding evidence to Theory B.
Yeah, well, as you mentioned, it's so important to really help them understand that Theory B, because we're providing them with actually an alternative explanation to what they went through, helping them understand that actually it's a normal response, but in this case, it's a wrong alarm. Once we do that in Theory B, yeah, as we said, I mean, they did a physical checkup and they haven't really trusted what the doctors said to them. They're almost certain they have a physical problem. And due to the negative anticipation, they actually keep going into those attacks. So by the time they come to us, Yasemin, usually you and I know that they've been living in that sympathetic system, or at least coming in and out of that system several times. I mean, they maybe went through that, gone into the system 3 days ago, then again a few days later, and then again. I mean, they've been coming in and out of it. So actually we have a system and body that's very exhausted, muscles that are tense. and the breathing that has gone off. So when we start with physical symptoms after psychoeducation, one of the first things we do is actually try to rearrange the breathing. And in terms of breathing, I mean, what's most important is to return to what we call the diaphragm breathing. And again, I think it'll be helpful to show this over a diagram because I think it will help them understand better. Now, diaphragm breathing, it's breathing from what we call the muscle diaphragm. But how does this make sense? I mean, usually in the case of panic disorder and panic attack, our breath goes upward to the area of the lungs. And since we have the rib cage in front of the lungs, I mean, here too, I have the bones. Due to this, the breath I take in, I mean, is much shorter than this area where it's soft and nice, no bone. So, I mean, here, breath is upward right in the lungs. And due to this, I mean, the amount of oxygen that's coming in is maybe around here or here or here, maximum around here, but still there's a large gap between the oxygen that is needed for the survival of the muscles and for the parasympathetic system to be in action. There's still a large gap. So we try to teach them diaphragmatic breathing, which allows what? When we breathe from a diaphragm, I don't know, Yasemin, is it clear?
Yes, it is.
The muscle the muscle kind of moves 3 centimeters downward. And this allows, I kind of drew these like wiggly things. This allows the lungs to move into actually the rib cage free area, which allows the remaining oxygen needed for the body to come in. This is very significant because once the body gets enough oxygen and the muscles get enough actually food to survive, it is more likely that this alarm system will switch back to the safe, calm system. So regarding physical symptoms and managing them, I do teach this diaphragmatic breathing. And I do teach this first because usually when we go to those relaxation exercises, because I mean, when I'm in fight or flight, you know, we kind of contract our shoulders, we're in like fighting mode or fleeing mode. I mean, a lot of these muscles are all tightened up because again, I've been going in and out, and I mean, they're tense. So we first need to learn breathing though, because when we do those neck rolls or shoulder rolls, we do use this breath during the exercise. So kind of do this, but following this, you and I know we actually then go to exposure techniques to try to break those avoidance and safety behaviors, right? So why don't we talk about those, Yasemin? How do we do that? How does it move along? Yeah.
Okay. That's very informative, but I just want to highlight there, and we've been talking about this before as well. Breathing techniques are great for balancing the extra oxygen in our body, because with adrenaline rush, we get that extra oxygen, and we don't need that much. I guess the carbon dioxide and oxygen is imbalance, so we need to somehow calm the body. But it's important to make our clients aware that they don't use this as safety-seeking behaviors, and they use this as coping. And as we work with them and as they increase their awareness, they are aware of, when they are aware of the safety-seeking, they often know how to cope with this. So it's a management, and it's very informative.
Exactly.
And the other thing I just want to add to this is with panic attack, blood pressure usually goes up, right? And sometimes people interpret this as I'm going to faint, and if I faint, something bad is going to happen. And in the psychoeducation, when we tell them, actually, you will not faint when your blood pressure goes up, because you need your blood pressure to go down for you to be able to faint, unless you have a medical condition. So this information alone can really, and it's a relief. So I'm not going to faint. No, you're not going to faint because your blood pressure goes up. So this, and also what we know about anxiety is that there is overestimating of the situation and underestimating of the coping ability. So we underestimate, and it's that I can't cope in this situation. So I guess what you're saying there helps them to cope with the situation. So with the exposure.
Yeah, that point's very important. Exactly. They do see that bubble of the danger is really big, but the coping mechanisms are very small. That's a very good point.
Yeah. I'm also trying to follow the comments at the same time. Please keep them coming in. We're going to go on to the questions soon.
Yeah.
So
exactly.
With Panic, we did lots of practical things. And I love working with Panic because there's so much that we can do according to the presentation and this formulation that we do. So it can be different for each person. They don't always have the same cognition, same misinterpretation, same symptoms. What's effective is what we call behavioral experiments, and these are to challenge their thoughts, catastrophic misinterpretation, and also update their knowledge. So this involves dropping the safety-seeking behaviors, first identifying them, and we may do this in a gradual way depending on where the person is. We often create a hierarchy of feed situations, so we do this collaboratively. It has to be mutual way. We can't force something onto the client. So this may be whatever they're avoiding. So it may be the easiest step may be going to the corner shop and then the supermarket and then tube, for example. So we start with the least anxiety provoking 40% at least situation to challenge these beliefs. We often ask them, okay, what do you predict will happen in this situation that you've been avoiding? We get their prediction. What do you think will happen? Okay, so what do you need to do? So sometimes we can go with them, and research shows that therapists doing this with the client can be more effective, but not always possible. We can also set this experiment for between session tasks and get the client to do it and come back with the information. So we use lots of, papers and panic diary, perhaps. So they go and do this, and they look at.
I like the fact that you refer to it as experiments because, instead of assignment or homework, I mean, it's in this case, it's very important to refer to it as experiments. Like we go to do this experiment, and we state the cognitions they need to prevent, right? And the safety-seeking behaviors they need to stop, the avoidance behaviors they need to stop. We kind of outline it. Yeah, the term experiment is really nice.
Yeah. So it's the task for them to do in between, because 1 hour session isn't always enough. It needs to be practice for new information to be learned. So we get the anxious predictions, what they think will happen in that situation. And then they go on into the situation with new behaving strategy, of course, dropping the safety behaviors. And then we look at, okay, so what happened in this situation? What was the outcome? And what did you learn from it? So often, people see that dropping their safety-seeking behaviors isn't the worst thing. It's very fearful to drop it at first, and they see that, just like the man on the train, I guess, it wasn't really helping them to keep the elephant away. So, updating what they believe is going to happen. Doing these through practical tasks. We do different exercises in the session as well, which I can't go into detail. I guess it will be too much, but following that hierarchy of steps and gradually in a systematic way employing those is usually an effective way of working with.
Yeah, wonderful examples. Yeah, exactly. It could be not taking the water along, not taking the pill along. And sometimes they might even use us, right, Yasemin? They might say, is there something really not going to happen? And they might use us as safety seeking as well. And we need to be sensitive about that too in those exposure experiments that we do. Very good summary. But it does also happen that sometimes, I mean, we do teach them the breathing. We do give them muscle relaxation. We do give them the psychoeducation. They do understand it's a false reaction to a unharmful danger. I mean, they're all aware of this, but it can be, right, Yasemin, after 5, 6, 7 sessions, I mean, even after we did all these experiments, that some of these clients are still unhappy and they're still not really relaxed. It's not all of them, but kind of my clinical practice, it seems to be like if among 10 clients, like around 3 to 4 of them still are not that happy about the end results. Have you seen this? I mean, did you notice this? Like, how can we explain this?
Yeah, that's right. What I've seen in my experience is that the first cognitions we've identified, what we mean by cognitions is the thoughts. What we noted is I may have a panic attack, I may have a heart attack, I may faint, I may die, I may go crazy or mad, right? So these are the first primary cognitions that we've identified and targeted them. But there's also sometimes secondary cognitions. And these may be something like if I go on the tube and if I have a panic attack, then I will be noticed, people will judge me, I won't be able to cope with that. Or there may be sometimes cultural stuff. So people who, when I say cultural, we live in a collective society, and there's a lot of interference in relationships. There's a lot of, I guess, black or white thinking. There's a lot of what will people say, fear of judgment a lot. When I was referring to behavioral experiment, I used to do them easily in London, for example. But it's different in Turkey because of the cultural difference. So I guess a lot of people live in extended families and they can't say no, and there's lack of boundaries. And all of these things also add, I guess the stress and accumulation of life events and situations and stress can also lead to other problems in panic and can maintain and continue because of the secondary cognitions, I guess. What would you like to add to that?
Yeah, exactly. I mean, you did say a really good point because, I mean, they do think it just happened out of the blue, but in fact, in those, not in all 10 of those clients, but in like 3 to 4 of them, it's in fact really not out of the blue. I mean, there is something, I see that this increasing line here that is stress or fear buildup may have to do with the fact that they have the tendency to not deal with issues that surface. They kind of postpone it. As you mentioned, it can be linked to the culture a bit. They kind of put their needs like after the needs of others. The priority is the needs of others. There is a tendency to have an other directedness. And even in schema therapy, there is a focus on this. For example, a little among our team, there are also people working on this issue because of this tendency to focus on others. There could be actually stress and fear buildup. And so actually that panic attack was not really out of the blue in those cases, the 3 to 4 people. Also, I mean, I noticed, Yasemin, they can have like an excessive need for approval, right? With lots of shoulds and musts, like I need to be strong or I should be strong. I need to always be in control. I must be in control. There is a kind of focus on shoulds and musts, I think. I noticed that a bit. The only other point I think that I seem to notice is actually these people do have a kind of genetic predisposition a bit, and they do have a bit more reactive bodies. I think you'd agree with me. Some of them, in fact, are more reactive, so their bodies are more reactive, and they actually might see this as a weakness. But in fact, we need to help them understand that in all personality traits, I mean, we can see it as a spectrum. Even an introversion or extroversion, it can be, or being organized and disorganized. I mean, having a reactive body and not having one, if we look at a spectrum, just as other personality traits, they need to see it's kind of a normal variation on a certain personality trait and maybe try to learn to accept this. This too can be a factor maybe in them not really being happy after we've done all the necessary methods to treat panic disorder or panic attacks.
Yeah. I guess it can come with its complexity, and I have seen this difference working with diverse group of clients in London compared to here. I guess, like I said, the religious side of things, faith, cultural things all come into play. The perfectionism, especially, I guess, the musts and shoulds and the rules that we build over time. And it's important to look at all of these and look at the unfinished business we have in our lives and the baggage, emotional baggage that we carry, and all of those things that you've said as well. I'm aware of time and there's some good questions coming through. Shall we perhaps sum up a little? And I mean, if there's interest, we can do part B, depending on, exactly how people find it. And
sounds good.
Yeah. So to sum up, I guess anxiety is a human condition, and we're not trying to get rid of it. We're just trying to increase people's threshold to anxiety, to stay with these symptoms that they're feeling, to learn, increase their tolerance to anxiety, and I guess increase awareness of these vicious cycles and thought processes that they have, and some of the rules, perhaps. What would you like to add to that?
Yeah, I think it's a good sum. I mean, that it's possible to have, these reactions in the times of danger, but sometimes there, in fact, might not be danger. And also that once we do understand the reasoning behind it, actually, I mean, it's actually not a scary event. It can be treated. Usually, we don't need medications most of the time. I mean, it is a condition that in which psychoeducation and psychotherapy achieves a lot, as we noted. So even if they're afraid and it's fear-provoking, they can know that there's treatment. I mean, we're hopeful on it. And as we mentioned, with these experiments and breathing techniques, and then if those are not adequate, understanding some personality traits or tendencies, there's wonderful results that we can achieve. So we're hopeful, I think, right, Yasemin, together? I mean, it's a hopeful condition. It's not that fearful.
It is. We've seen so many great outcomes, definitely.
Yeah, right, in general. I mean, it's a condition that in the end, we do see many clients who leave our clinic smiling. So I think that's a nice situation. In this sense, yeah. So,
what I also see is that once they have the awareness of what's really happening and that the situation isn't dangerous, they also help their surroundings as well, and they often report that. Oh,
yeah, right, because they changed so much. I mean, they were in that cycle where they were certain they had either a brain tumor or a serious physical problem that people were not understanding. I mean, then realizing that, in fact, it's psychological, it's not physical. Yeah. And it's such a big light bulb, right? I agree. They kind of want to spread the word everywhere. So they're nice results. I mean, they don't need to worry, I can say. There is help out there for this condition.
Definitely. So there's
so questions.
Yeah, so you had a question.
Yeah, I see a question coming. I saw it in the beginning, was coming through. Yeah, this person wrote this. She's saying, I started mindfulness meditation and the breathing got me a bit panic feeling. The sensation that I got when I had my panic attacks came back and it was confusing, as breathing is the one thing that's always said to allow you to get in tune with self and ease panics. She's continuing to add, I had to calm myself from my mind and go into a normal breath rather than a deep, long, focused breath, which sort of pressurized my chest and self as a whole. So maybe my question can be, are panic attacks purely controlled from our minds? Now here, yeah, good question, right, Yasemin? Here she's actually saying that the breath scared her a bit and was not helpful, actually. And she's trying to emphasize if the mind's more important. I would like to say that most likely in this case, the breath brought panic. She's most likely one of those people, you know, I said like out of the 10, 3 or 4 of them tend to not feel that well after all these methods. This is most likely linked to the fact that because she's been going in and out of that panic attack cycle several times, her body's been away from that breath for a very long time. So most likely when she went down to that deep breath, that old, happy, relaxed self must have come to her mind, because most of these clients, you know, too, I mean, they've been suffering from these symptoms for so long. It's like their life's gone into chaos. They're not happy anymore. Their hair's falling out. They're sad. They're not sleeping well. So if she's had sadness surface and difficulty breathing surfacing while she's breathing in the deep breath, most likely it's a memory of the past, because that breath has not been happening for most likely a pretty long time. So there, we need to actually still help them continue do the deep breath and realize and tell their body, you know, I'm going to be aware of what's happening in the past. I'm going to try to learn what I was doing wrong. So I don't need to be afraid. My body, please come on and trust me and continue with me and keep breathing with me, because it is the right breath. No matter what, we do need to do the diaphragm breathing. We need to allow the oxygen to come back in. If it's bringing up emotion, then we're one of those people who has neglected something for a very long time, and due to this have forgotten this breath for a very long time. So going back to it is bringing up a lot of emotion. It has to do with that. It doesn't have to do with the fact that another panic attack is going to happen. Absolutely not. Mm-hmm. It has to do with the history and remembering themselves in their past form. And they need to continue submitting to it and continue the breath because it's the right breath. I would advise them to then go on to see what they must have been neglecting and really try to dive into that, because there is a hookup that's going on there in their subconscious.
And I think the question came from a male, by the way. It's glad we've got a question from a male.
Oh, yeah, very good question then from a male too. Yeah, that's a good point. And there's another question, I think. Do you see any questions? Should I continue with this one, or are you checking questions, Yasemin?
Maybe I can answer one. So I'm just going to read.
Yeah, you answer it. Then after that, let me check if we can answer this one too.
Okay, Nina Hammond actually answered the guy on the train, I think, and also added a comment by saying that bodily symptoms of fear which are unpleasant but not dangerous. And there's also good comments about the subject as well. Let me just see. There was a question here. I think someone asked, what's the difference between anxiety attack and panic attack?
Oh, well, good point. It's a similar question. I got the same one here, similar one.
Oh, okay. So just being aware of time, I would say that anxiety attack comes on gradually, and panic attack comes on like a whack. So panic attack peaks within the first few minutes up to 10 minutes and may last for about half an hour. But anxiety attack, although it feels like the same symptoms, it doesn't happen like a whack. It doesn't happen that suddenly. And also the catastrophic misinterpretation, I guess, is different in panic as well. And also the symptoms afterwards, I guess, it can last a bit more. So it comes on gradually and lasts, continues more. It can be an accumulation of stressful things as well.
Yeah, exactly. I mean, when we look at our book, we usually diagnose conditions, together, you and I, too, according to the DSM, which is the 5th version now. And there we can't diagnose anxiety attacks. I mean, you and I can diagnose anxiety symptoms, we can diagnose anxiety disorders, we can diagnose panic attacks, and we can diagnose panic disorders. But anxiety attack is actually not something we can diagnose, so it is open to interpretation. But just as you said, I totally agree. I mean, in this case of anxiety, it happens actually not in a whack. And also, usually in the panic attack, it is like out of the blue, as you and I said throughout this program. But an anxiety attack, Yasemin, they usually know why they're anxious, right? They're usually like, for example, one might be anxious. For example, I knew one case where there was a wedding coming up, and I mean, there was this relative she's not getting along with, and she was really anxious about maybe attending that wedding and coming face to face with that person. So this was happening days beforehand. And I mean, she's aware of actually why she's having anxiety. In the case of panic attack, as you and I said throughout this program, we're not really aware of why it happens. Only later are we aware of maybe it's because we've neglected something, or we've not accepted ourselves, or we have shids and must too much, but that's later on. Usually it's because out of the blue. But in anxiety, usually, I mean, they do have an awareness of why they're anxious. And sometimes they might be so anxious, right, Yasemin? The anxiety attack might actually turn into a panic attack. I mean, right? They might be anxious for a really long time, and they know the reason, but it might transform into a panic attack, kind of. But yeah, we can say that. I mean, we're more aware of it. And as you mentioned, it's not in a whack, and it's usually longer in duration. But still, it's open to interpretation because we can't diagnose it, as you and I know. Yeah.
Yeah. That's
Any
true.
other question? Like,
Do you want to answer? There's one about how can one get rid of the avoiding methods or their way of escape?
How can one get rid of them? Well, I mean, first of all, I think this might help because they're in their brain, right, Yasemin? They're saying only if I bring this water, I'm okay. And actually, that's telling their brain that, I mean, to prevent the attack, we need to do this. So it means there's an attack. Attack's coming. So if we actually say, no, we're not going to do that. I mean, we're not going to do this. Then the body might say, well, an attack's not coming. So it might actually be, you know, for example, they say to go to this area, you need to follow these directions, do this and that to get to that area. We need to do that. So to have an attack, we need to do that. But actually, if we don't do that, there's no attack, just as we're not going to that address if we're not following those directions. So I think it's them maybe realizing like it's part of the recipe. If you don't add it, the attack's not going to come. It might be like maybe excluding it out of the recipe and just don't do the recipe. Cancel the recipe. That's kind of the method I use of it, because the more you do the list, the more you're following the recipe, the more it means that attack's really there when attack's not. I think that would be the advice I kind of would give.
Yeah, and I would also say maybe to have a better understanding, maybe seek therapy that's available, if it's available around them. I don't know where they are writing from. Professional help, CBT in particular, cognitive behavioral therapy, can be a good way to find out what they do in those situations and how to maybe change behavior if they want to, if it's impacting their life.
Yeah, like the experiments you mentioned, you actually touched upon them. Yeah, all those experiments can help them out, as you mentioned so perfectly. Yeah, so that's a good opinion too. Any other big question? Did it come, or should we close up? Time is kind of finishing.
Yeah, someone just said it's really interesting and said thank you, you're welcome, very informative. Thank you for. Is there going to be a discussion about dissociative identity disorder? There was one. You can find it on Medaim Yanık's clinic.
Oh, talking about that, yeah, it's a good point, because the therapy talks will be continuing, right? Yes, I mean, we can mention that.
Yes, I think.
She reminded, whoever wrote that reminded us. I was forgetting about it.
Thank you. Thank you.
Yeah. Therapy talks.
There's other comments as well. Thank you very much for all the comments. I just want to sum up that panic disorder can be a very uncomfortable physical feeling, but it's important to understand what really happens in the body, the fight or flight response, the anxiety cycle, and there's treatment available. It can be effective, and they don't have to live with this. It can be debilitating the life. It can be affecting all areas like work and relationships. I hear so many people who lived with this for years and they didn't get treatment, but they stopped going out. You know, they don't feel that pleasure anymore, sense of achievement. They lose out on so many things. And I would suggest seeking help can be really helpful in these situations. And we have 1 minute left. Do you want to announce the next?
Yeah, exactly. Good summary, Yasemin. It was really nice, by the way, having this conversation with you. Thank you so much. And so our therapy talks will be continuing on Wednesday, again at 9 p.m. And the topic this time is going to be about how to decide on a good spouse, actually. I'll give this section in Turkish just because let it be in harmony with the title. So it's Medaim Yanık ve Pınar Koç Yıldırım'la terapi sohbetleri çarşamba günü saat 9'da Evet Demeden Önce isimli programla devam edecek. And thank you everyone for joining us.
Thank you so much for everyone. I hope for the helpful discussion. Thank you for listening, and thank you for contribution as well. Someone asked, will there be a talk on mindfulness? Nena, actually. I hope so. On mindfulness.
Yes, perhaps. We got used to these talks, right? Yeah.
Yeah, we are, I guess.
Perhaps.
COVID started us having these live, maybe we can put that on our list. And why not? It will be interesting to have third wave, maybe acceptance and commitment therapy, and maybe mindfulness as well. Why not? You're welcome. There's a lot of, yeah, thank you. So thank you everyone for listening to us.
Yeah. Thank you.
Yeah, you're welcome.
Okay.
So good night.
Yes, good night everyone. Good evening. Good evening, Yasemin then.
Good evening.
Okay, yeah. Bye-bye.